Hello and welcome back to Counter 10. In today's episode, we're going to cover Applied Respiratory Physiology. Now, this is a big topic in the respiratory section, and it can be quite intimidating to approach the first time you look at the learning objectives. What makes it easier is thinking that this is just a culmination of all the previous episodes that we've spoken about. So it's putting all that information into one learning objective. We're going to cover quite a lot of information in this episode, and there's a lot of learning objectives and SAQs to get through. We're going to start off by talking about the physiological basis for preoxygenation, then move on to changes in the respiratory physiology with posture, aging, obesity, and then finally look at causes of hypoxemia and hypoxia and relate this back to the clinical picture. There's a lot of key SAQs that I want to get through from the ANSCA and the ICU exam. So let's stop wasting time and dive straight in.
1, 2, 3, 4.
Now, the first learning objective is describe preoxygenation, including its physiological basis. Now, everyone knows what preoxygenation is, but this learning objective really wants you to get technical about it and know all the details associated with preoxygenation. So to start off, we can say that the definition of preoxygenation is the process of denitrogenation of the FRC and replacing it with oxygen. So normally we have nitrogen concentration between 78 to 79% and an oxygen concentration of 21%. The FRC is our ERV plus RRV. So in a normal 70 kilo person, this is approximately 2 liters worth of lung volume. This 2 liters represents a huge reservoir that we can use as a way to store as much oxygen to increase the apnea time in a patient before they start to desaturate. We can figure out how much oxygen is in the FRC at rest by relating it back to the alveolar gas equation. We know that normally the ideal alveolar partial pressure of O2 is 100. So if we divide 100 by 760, which is the normal barometric pressure, and times this by the volume in the FRC, which is 2 liters, we get that the amount of oxygen at rest is approximately 260 mils. Normally in a 70 kilo adult, the oxygen requirement is 3 to 4 mils per kilo. So this is equal to 200 to 250 mils per minute. So in a patient that hasn't been preoxygenated, the oxygen at rest will be utilized within 1 minute of apnea time. If we now fill the lungs up with 100% oxygen, we can increase the partial pressure of alveolar O2 to 660. So 660 divided by 760 times that 2 liters means that we now have 1800 to 2000 mils of oxygen as a reserve. Now we can increase that apnea time before desaturation to approximately 7 to 8 minutes. And that's really the most important thing to understand when we talk about preoxygenation. Now, the technical parts about preoxygenation is how long we should preoxygenate the patient for. This relates back to the concept of time constants in a lung. We need to give adequate time for the nitrogen to be out of the body and it to be replaced with oxygen. One time constant of a lung is approximately half a minute. And we know that when we get to approximately 4 to 5 time constants, we allow that physiological process to be complete. That's where we get the number of preoxygenating the patient for approximately 2 to 3 minutes before we induce them. The other option of preoxygenating a patient is using, instead of tidal volumes, vital capacity breaths. So if we do this, we can preoxygenate the patient quicker, and within 5 to 10 vital capacity breaths, we can achieve the same end goal as our tidal volume breaths that took 2 to 3 minutes to achieve. Now, what happens if we don't preoxygenate the patient and they become apneic? Sometimes they like to ask this in a viva setting, and there's really 3 scenarios that can occur. The first one is where the apneic patient has an obstructed airway. The second one is where the apneic patient has a patent airway. And the third one is where the apneic patient has a patent airway and can get supplemental oxygen. Now, in the first scenario, if you can imagine, in the obstructed airway, there's 250 mils of oxygen moving into the body and 200 mils of CO2 moving out of the body. Within 10 seconds, the CO2 quickly equilibrates, and within a minute, the oxygen reserve has already been used. after which the partial pressures O2 also equilibrate, and the CO2 continues to rise at a rate of 3 to 6 millimeters of mercury per minute. Now, if we relieve this obstruction, we can allow more oxygen into the patient via a concept called mass inflow of gas. This is a passive way to oxygenate the patient, and it essentially works on a simple principle. This is because as the lung volume decreases, the alveolar pressure becomes subatmospheric, and now there's a gradient between the pharynx to the alveoli, which favors the movement of gas down from the outside of the body into the pharynx, down into the lungs itself. And this is why in the resus situation, the simple maneuver of making sure there's no airway obstruction can be the difference between life and death, because we can extend our apnea time before desaturation occurs by another minute or so. The final scenario is in the patient who's apneic with a patent airway who's receiving oxygen. And again, it's just using that simple concept of the mass inflow of gas. Along with the constant stream of oxygen, we can now delay that time for desaturation exponentially. Some theoretical studies have said that with high flow oxygen on, the time to desaturation can be as long as 100 minutes. With Thrive, the longest time I've seen reported has been around about 55 minutes. Now just keep in mind that the CO2 still rises, but it's not thought to be as rapid as the 3 to 6 millimeters of mercury per minute. With Thrive, the rise is much slower. Now just to finish talking about preoxygenation, we have to relate it back to some clinically relevant situations. Situations where a desaturation would occur faster than what is expected. For example, in obese patients, when they have a reduced FRC, they'll have a quicker desaturation time, as well as the fact that they have an increased metabolic demand. In pregnancy, we have both a decreased FRC and an increased metabolic demand and oxygen requirement. Same with children. Children have a much higher metabolic demand and oxygen requirement, nearly double that of adults. And then in the critically ill patients that are septic or just unwell, their metabolic and oxygen requirement is also higher. So I think that's a pretty comprehensive review of preoxygenation, and we'll move on and talk about our next learning objective, which is describe the physiological consequences of anesthesia and patient positioning on the respiratory system and their management. This is really two learning objectives in one. The first part is what really happens with anesthesia on the respiratory system, and the second part is how positioning affects the respiratory system. It's well known that with anesthesia, FRC decreases. So during anesthesia, with all anesthetic drugs, FRC decreases by approximately 15 to 20% from the awake FRC. This drop in FRC happens right after induction, and it only takes a few minutes to occur, and there's no further fall in FRC due to anesthesia alone after this. There are really two reasons why this decrease occurs. The first one is that there's a change in the chest shape. So there's a decrease in the cross-sectional area and a total decrease in the total lung volume by around about 200 mils. So the anterior-posterior diameter decreases overall in the supine position. And the second reason is that there is a movement of the diaphragm cephalidly. This causes a loss of our end expiratory tone and also causes atelectasis. Any person that's having an anesthetic is pretty much guaranteed to have some degree of atelectasis. In nuns, if you read it, it says approximately 98% of healthy individuals having a GA with muscle paralysis will have some degree of atelectasis. And this atelectasis always seems to occur in the dependent regions of the lung. Now, there's a lot of implications of the decrease in FRC on our respiratory physiology, and this kind of links in really well with the effects of different patient positions. So in the supine position, our FRC is going to be decreased by that 10 to 20%. And as our FRC decreases, it's getting closer to being lower than our closing capacity. If our closing capacity is higher than FRC, we're going to have small airway closure. This is going to lead to further gas trapping and be a cause of a shunt in a patient and lead to VQ mismatching. Secondly, because our lungs are not at FRC anymore, we're not on that steep part of our compliance curve. There's increased work of breathing due to this decreased compliance, as well as decreased matching of our V and Q together. On the same line, there's increased airway resistance because now we're reducing the total lung volume, so we're reducing the airway caliber size. And finally, we're also affecting our pulmonary circulation. Remember last episode we said that at FRC we have the best balance between our extraalveolar and alveolar vessels. Here, we're shifting that graph to the left and increasing our PVR. So a good understanding of that base position allows us to then extrapolate what's going to happen with other changes in position. For example, if we look at Trendelenburg and reverse Trendelenburg, we can say that in Trendelenburg position, we're going to exacerbate our cephalad displacement of the diaphragm. This is going to make our FRC even less, and it's going to lead to an even more negative effect on all those respiratory consequences. In a reverse Trendelenburg or a head-up position like what you'd have in beach chair, it's favoring our respiratory system. We're allowing our FRC to be increased by decreasing that cephalad displacement of the diaphragm. So we're decreasing atelectasis, we're decreasing our VQ mismatching, we're decreasing our airway resistance, we're decreasing our work of breathing, we're decreasing our aspiration and regurgitation risks, and we're allowing our PVR to be closer to that optimal level. The other position that we might see patients in is the prone position. This position is quite unique for the respiratory physiology and actually allows the best VQ matching to occur. The reason is, in the prone position, the anterior chest is now receiving all of the blood volume because of gravity, and the anterior chest is also on the steep part of our compliance curve. So our ventilation and perfusion is being best matched in the prone position. The caveat to the prone position is that you actually need to have the right bed to allow the best matching to occur. Now, to summarize our patient positions, remember to think about supine as your base, and the trick is, if you think about anything where you're going to be Trendelenburg or head up as going to be better for favoring your respiratory physiology, and anything where you're head down as going to be worse for your physiology, it makes it a lot easier to think of all the factors. The next learning objective is discuss the physiological consequences of intermittent positive pressure ventilation and PEEP. IPPV can be thought of as two phases. It's the use of positive intrathoracic pressure to ventilate the lungs on inspiration, and then the release of that pressure to deflate the lungs with expiration. Now, the physiological effects are related to the increase in mean airway pressures and the increase in intrathoracic pressures, which are all influenced by the mode of ventilation, the settings of ventilation, and PEEP itself. PEEP is defined as a positive airway pressure at the end of expiration. Now, when we think about IPPV, there's a lot of positives as well as a lot of negatives associated with it. It allows us to take control of the patient's ventilation, which then allows us to set a tidal volume, a rest rate, and a minute ventilation, so we can control the patient's CO2 and therefore help to control their acid-base balance. We're artificially ventilating them, in which case we're reducing the work of breathing. And we can use different modes to have other desired effects that can help to improve oxygenation. Unfortunately, there are a lot of negatives with IPPV as well. We get an increased VQ mismatch because we get differential ventilation to the non-dependent and the dependent lung, and so ventilation doesn't match perfusion anymore. We get a decrease in lung compliance because usually IPPV is associated with the patient being in a supine position and a decrease in FRC. And as soon as we decrease FRC, we get all those other negative associated effects. The other negative effects of IPPV can be then divided into the physical effects. So it can cause volume trauma, barotrauma, or biotrauma. In worse situations, we can cause pneumothorax, and that's why we typically recommend lung protective strategies when we're giving patients IPPV by ventilating them at 6 to 8 mils per kilo of their ideal body weight. IPPV also has effects on the cardiovascular system. This is too much to go into today, but we will explore this in our cardiac physiology topics. The way to think about PEEP is that it's our artificial way to counteract what anesthesia does. So it's our way of trying to balance that decrease in FRC and try to keep it as minimal as possible. Now, PEEP can also be harmful, and it depends on what amount of PEEP you're applying to the patient. So we can divide this into mild PEEP moderate PEEP, and severe PEEP. Typically, mild PEEP is at 5 centimeters of water, moderate is anywhere between 10 centimeters of water, and severe or high is when we get above 15 centimeters of water. What PEEP is trying to do is trying to keep the airways open, so it can help to prevent atelectasis, help to prevent gas trapping, it can help to decrease our VQ mismatching, it can improve our lung compliance because it's being closer to our FRC, it can help to decrease our airway resistance because now we're closer to FRC, it can help to decrease our work of breathing, and it can also be a way of moving fluid out of the lungs and be a treatment for pulmonary edema. But when we give too much of PEEP, we start to have those negative effects occurring. We start to actually get increase in our VQ mismatching by decreasing our venous return, which leads to an increase in our West Zone 1. We start to get a decrease in our lung compliance by shifting the compliance curve too far to the right. We then get an increase of work of breathing because of that. We get an increase in our pulmonary vascular resistance and our right ventricular afterload. And just like IPPV, it can also cause barotrauma. So to summarize the effects of IPPV and PEEP, IPPV has positive and negative effects on the respiratory system. It helps us to control the ventilation and artificially manipulate it, but at the same time, it leads to all the negative side effects associated with a decrease in FRC. PEEP helps to decrease those negative side effects, but only to a certain point. If we give too much PEEP, we then lose the balance between the benefits of it and the negative cardiovascular and respiratory side effects. Along with this, it also has negative side effects on other systems. So in the renal system, it can decrease our cardiac output and decrease our renal blood flow. It can cause a decrease in hepatic blood flow. It can cause a change in our Monro-Kelly doctrine by impeding our venous return and therefore leading to an increase in ICP. And it can also cause some minor hematological effects by causing neutrophil sequestration in compressed pulmonary vasculature. So we always need to weigh up these effects in a clinical context. Now, our next learning objective is discuss the effects of the following on ventilation. This includes the change in posture, exercise, altitude, anesthesia, aging, and morbid obesity. We've kind of already discussed the change in posture, so we'll tackle the rest instead. Really, when we're asked to discuss the effects on ventilation, you need to have a good structure on how you're going to tackle this in the SAQ format. My way is to break it up in the headings of our topics in respiratory physiology. So I like to group it as thinking about mechanics of breathing and then incorporating within that airway resistance, compliance, and then muscles. Then I think about gas exchange, and here I incorporate closing capacity, VQ relationships, and lung volumes. Then I think about control of ventilation, in which I can put effects of drugs and normal control. And then finally I think about all the other spare things, like the effects on the upper airway and reflexes. And then finally, the last thing I like to think about is always the clinical context or the clinical implication. So we can apply this and think about the changes in ventilation in an aging patient. In the aging patient, pretty much all the subheadings are dramatically changed. In terms of the mechanics of breathing, the airway resistance is increased because of a loss of the radial traction due to a destruction of that elastic tissue. There's a change in the lung compliance. Because there's decreased elastin, there's an increase in lung compliance, but a decrease in chest wall compliance because of the ribs being calcified and associated conditions like hyperkyphosis with aging. So overall, the respiratory compliance decreases. This leads to an increase in our work of breathing, which is exacerbated by a decrease in our muscle fibers and a loss of our slow, long-acting muscle fibers. In terms of gas exchange, our closing capacity becomes higher than our FRC, and so with normal tidal volume, we get gas trapping occurring. This can lead to atelectasis and therefore increase our VQ mismatching. We therefore get a bigger shunt and a lower partial pressure of arterial oxygen as we get older, and this leads to a higher AA gradient, and the typical quoted number is that the AA gradient increases by 1 millimeter of mercury per decade. We also get a change in the overall lung volume, so our total lung capacity decreases with age, our FRC increases with age, and our minute ventilation decreases with age. Our control of ventilation is also affected. So in the aging population, we're more sensitive to the effects of drugs such as opioids. We have a decreased response to hypercapnia and hypoxemia. We have a decreased sensitivity of our chemoreceptors, and we have a decreased ability of our muscles to respond to a change in our minute ventilation. The aging population also has a change in their upper airways. There's an increased risk of aspiration due to the decrease in protective airway reflexes. The cough becomes less effective as we age, and the sensitivity of this reflex arc also decreases. There's an increased risk of developing sleep apnea because we lose our upper airway pharyngeal tone. So then putting it into the clinical context, in the aging patient there's an increased risk of respiratory failure because there's a decreased ability to compensate adequately for any changes in clinical states. We can use this model and then apply it again in the obese patient and say that their mechanics of breathing are also greatly affected. They have an increased air resistance again due to decreased lung volumes. They have changes in their chest compliance because of the increased weight on the chest. So therefore they have an overall increase in their work of breathing. In terms of their gas exchange, they have a higher oxygen consumption and a higher CO2 production. The FRC is lower, and when we anesthetize them, we cause another further decrease in their FRC. So we get an increase in our VQ mismatching. That FRC can be below closing capacity. So therefore their arterial partial pressure of oxygen can be lower and increase their AA gradient. In terms of their control of ventilation, they can be more sensitive to drugs like opioids. And in terms of their upper airways, they can have fatty infiltration. They're a higher risk of difficult intubation and difficult bag masking. They can have increased incidence of associated conditions like OSA or OHS. And then clinically putting this all together, if they have lower FRCs and a higher oxygen consumption, they're going to have a faster time to desaturate. Along with the fact that they're going to be more difficult to intubate, it leads to an increased incidence of CAICO events. They're going to have a greater degree of a decrease in FRC with induction of anesthesia. So this is going to lead to atelectasis and a greater mismatching of their VQ, leading to a greater degree of shunt and hypoxemia. Now, I'm not saying you have to use this structure all the time, but you just need some structure so you can cover off all the main headings covered through the respiratory physiology topic. Now, there's two more states I want to talk about, and that is exercise and altitude in this learning objective. And the reason I want to talk about them is because they kind of have unique effects on the respiratory system. Exercise is a very unique one, which we still don't know much about or why it occurs. So with exercise, there's an increase in ventilation that occurs promptly as soon as we start exercise. In a fit young person, our oxygen consumption can go from being at that baseline 3 to 4 mils per kilo all the way up to being 40 to 50 mils per kilo. To meet this oxygen requirement, our minute ventilation increases promptly and can be nearly 15 times that of resting level. In saying that, our pH, our partial pressure of arterial O2, and our partial pressure of arterial CO2 doesn't really change early on in exercise. The changes in minute ventilation can be depicted on a graph in different phases. The first phase is this rapid increase in our minute ventilation. Our second phase is this plateauing phase where we're matching ventilation to our oxygen requirement. And then we reach this third phase where we kind of reach the end of our plateau phase before we stop exercising. Only when we get to the point where our aerobic metabolism can't continue, and this is called our anaerobic threshold, that's when we start to see acidemia occurring, our oxygen levels drop, and our CO2 increasing. And that's key to know in the back of your head if you ever get asked about exercise. Now, with altitude, we've already kind of discussed our 3 phases of change in ventilation in our very first episode, Control of Ventilation. I just want to touch quickly on the adaptation effects that occur because of altitude. So overall, if you were to stay at altitude for a long time, you would start to get polycythemia occurring to help with our O2 carrying capacity. You would start to notice an increase in capillaries at the tissue bed to improve oxygen offloading. Your ability to exercise would be decreased compared to normal. You'd have an attenuated response to hypoxic pulmonary vasoconstriction because at altitude this is actually counterintuitive and you want to ablate that response. You would start to get negative side effects of having that hypoxic pulmonary vasoconstriction occurring, and these would be things like an increase in our PVR leading to pulmonary hypertension, a right ventricular hypertrophy, all of which can lead to right-sided heart failure. So these patients can commonly present with symptoms of fatigue, reduced exercise tolerance, and severe hypoxemia. Now, let's move on and talk about some learning objectives revolving around hypoxemia and hypoxia. The first learning objective is outline the causes of hypoxemia. We should be able to get through these quite quickly, and they all make logical sense. Hypoxemia is typically defined as a low partial pressure of oxygen in the arterial blood. The normal level which is referenced is less than 60 millimeters of mercury. There are 4 causes of hypoxemia, the first one being hyperventilation, the second one being diffusion limitation, the third one being shunt, and the last one being VQ mismatch. Hyperventilation is super easy to understand. If you're not breathing, you're going to be increasing your partial pressure of CO2. You're going to relate this back to your alveolar gas equation, and you can see how if you increase your partial pressure of CO2, you get a decrease in your partial pressure of O2. This cause of hypoxemia is commonly encountered in our everyday practice, and you can easily treat it by giving the patient oxygen. Along the same line, diffusion limitation also has a good response to oxygen. Diffusion limitation occurs because it's the destruction of our normal gas alveolar blood barrier, and so there's not enough time for the oxygen to travel from the alveoli into the blood and bind to the red blood cells. This limitation is governed by factors that affect Fick's law. So if you increase the diffusion distance or change the diffusion path, for example, if a patient has APO, this might be a cause of hypoxemia. Again, it has a good response to oxygen, unlike our next cause, which is shunt. We've already spoken about what a shunt is, and it's simply just wasted perfusion. So it's VQ areas that equal 0. If the shunt fraction is less than 30%, there'll still be some response to oxygen, but as soon as it becomes above 30%, that's when we start to get to the point where there's no kind of improvement with giving the patient oxygen. Our last cause of hypoxemia is VQ mismatch. Now this is different to shunt because this incorporates all lung units that don't have a VQ that equals 1. And remember, this relates back to our oxygen dissociation curve and the shape of it being sigmoid. Because we have areas in our lungs that are really well ventilated and areas that are really poorly ventilated, those two areas can't compensate for each other because of the sigmoid shape of our ODC. And so therefore we get this heterogeneity of VQ matching throughout the lung, leading to hypoxemia. The way we can differentiate among these 4 causes of hypoxemia is 1, looking at that response to O2 that we've already spoken about. Secondly, looking at the AA difference. So the AA difference will be increased in diffusion limitation, shunt, and VQ inequality, but it won't be increased in hypoventilation. And then the last way we can look at it is by looking at the effects on CO2. So hypoventilation and VQ inequality can be causes of hypercapnia, while the other 2 are very unlikely to be. This discussion of hypoxemia leads us to talking about hypoxia. Hypoxia is defined differently to hypoxemia in that hypoxia is oxygen delivery to the tissue that is inadequate to meet metabolic demand. Just like hypoxemia had 4 causes, hypoxia also has classically 4 types. The first type is hypoxic hypoxia. This is caused by low partial pressure of O2 in arterial blood. So this cause of hypoxia encompasses the 4 causes of hypoxemia. The next cause of hypoxia is anemic hypoxia. So this is a reduced ability of blood to carry oxygen. So typically you'll see this in patients that might have anemia or carbon monoxide poisoning. Then we have circulatory hypoxia, sometimes also called stagnant hypoxia. This is caused by a reduction in the tissue blood flow. For example, what we see in patients that are shocked or have local obstructions. And then finally, we have histotoxic hypoxia. This is hypoxia that's caused by a toxic substance that interferes with the ability of the tissue to utilize the oxygen. For example, when someone has cyanide poisoning, and this causes impedance of the cytochrome oxidase on our electron transport chain. There's a really nice diagram in MAC 95 which connects all these terms, hypoxia, hypoxemia, and then each cause along with dead space and venous admixture, all into a Venn diagram and shows how they all relate to each other. I would highly recommend just looking at that diagram just so you can grasp an idea of the different types of hypoxia, hypoxemia, and all these different definitions that kind of all being jumbled into one in your brain after a while. Now there is a few more learning objectives to cover in applied respiratory physiology. However, I think the best bang for buck would be to move on to some SAQs. Now the first SAQ was asked back in 2014 in the ANSCA exam. It was, describe the physiological basis of methods used to prevent hypoxemia prior to intubation in a rapid sequence induction. Include any adverse effects of these methods. Given how much time we spent at the start talking about preoxygenation, it's hard to see that this exam question had a pass rate of 16%. It makes it a really high candidate to be asked again, and the examiner report was pretty straightforward. In order to pass, they said that you needed to demonstrate that hypoxemia is avoided by increasing oxygen stores and maintaining these oxygen stores, and then this would mandate a discussion about the role of FRC, preoxygenation as a means of augmenting that store, and that better answers would incorporate the alveolar gas equation. You could also talk about apneic oxygenation, and what was frequently omitted was the discussion of the adverse effects of these methods. So I think an ideal answer here would start off with a brief description of an RSI in terms of just saying that it minimizes the time from the loss of consciousness to intubation, and then you would say that the goal of preoxygenation is to prevent hypoxemia. The rationale is that you are trying to increase the oxygen stores in your FRC by removing the nitrogen, and you can incorporate the alveolar gas equation here to demonstrate how much oxygen there is in that space. You would link this up into the normal oxygen consumption in a healthy adult being 3 to 4 mils per kilo, and then you would say that if we replace all the FRC with oxygen, we can increase the time to desaturation to approximately 7 to 8 minutes. The other thing you want to incorporate with your discussion of preoxygenation is the discussion about time constants and how long it takes to do adequate preoxygenation. Once that's done, you would then talk about the methods of apneic oxygenation, the main one being high flow nasal prongs, and you could say that this works by giving a continuous supply of oxygen in a patent airway through mass inflow of gas. These are the two obvious ways that we do preoxygenation. The less obvious ways that we can also talk about preoxygenation is talking about PEEP, so giving the patient PEEP while we're preoxygenating them to help decrease airway splinting, maintaining FRC and to decrease the FRC drop with the induction of anesthesia. And the other way we can improve preoxygenation is by patient positioning. So we can have them slightly head up, and this will decrease the cephalic displacement of the diaphragm, therefore improving our lung volume and keeping it at the baseline FRC. Once you've spoken about these 4 basic mechanisms, you can then just make a table about these mechanisms and their adverse effects. You never want to forget the simple adverse effects, like the adverse effect of preoxygenation being anxiety to a patient because of a mask, applying too much pressure and causing trauma, the negative effects of high flow oxygen on the mucous membranes of the nose, causing things like epistaxis to occur, the negative effects of PEEP being patient discomfort and subjective dyspnea, And then the negative effects of positioning the patient head up, which would be with induction of anesthesia, you get a further exacerbation of a decrease in blood pressure, hypertension and SVR drop, and this could lead to an increase in West Zone 1 developing. So if you just think about this question logically, and remember you have to talk about preoxygenation, apneic oxygenation, PEEP, and positioning, you should have enough points to pass easily. The next SAQ was again from the ANSCA exam, and it was asked in 2005, and it's pretty much the carbon copy of one of our learning objectives. It was, explain the changes in FRC that take place with administration of anesthesia. To pass this question, the examiner report said that you needed to discuss the determinants of FRC, the time course of change with the general anesthesia induction, the explanation of the course of the change, so why this change occurs, and then additionally, you could talk about the change in the shape of the diaphragm, the exaggerated effects of abdominal surgery, the loss of the nitrogen splinting, the effects of PEEP to try to decrease this effect, but you really want to make sure you didn't get caught out by talking about the consequences, because that's not what they wanted in this question. So to answer this question, you could break it up into two parts. The first part would look at exploring FRC, so you could start off with the definition and say it's the volume of air left in the lungs at the normal end tidal expiration. It's your ERV plus your RV. What the normal values are, what the determinants of your FRC are, so these are your absolute lung volume, your relative lung volume, and your alveolar patency. The significance of your FRC being it's an O2 reservoir. It prevents alveolar collapse. It's the point of maximal compliance. It's the point where airway resistance is low, and it's the point where it's the lowest PVR. Then you would move on and talk about the effects of anesthesia on FRC. So you can say that with induction of anesthesia, we have the FRC decreasing because of two reasons. We have the loss of our anterior-posterior chest wall diameter. We have the cephalad displacement of our diaphragm and the loss of our end expiratory tone. These two things together lead to a 15% decrease in our FRC. And so it goes from being 40 mils upright to 30 mils supine to another 15% decrease on top of that. These effects are exaggerated with a head down position or improved with a head up positioning on intubation. They can also be improved by giving the patient PEEP. And then you can talk about different types of surgery and different types of patient demographics. So you can say intra-abdominal surgeries where there's a pneumoperitoneum will further exacerbate our decrease in FRC. Obese patients will have a further decrease in their FRC. And on extubation, when we lose positive airway pressure and there's coughing, we can further exacerbate our decrease in our FRC. To be fair, this question is very unlikely to be asked because it's been superseded by another question, which is what are the physiological consequences of decreasing FRC by 1 liter in an adult? This one is the question that gets asked more frequently, and we covered it when we talked about gas volumes and gas exchange. And here you would just talk about a definition of FRC, the roles of FRC as an oxygen store, the effects on lung compliance, airway resistance, work of breathing, pulmonary vascular resistance, and the effects on closing capacity, VQ matching, and then having an effect on shunt and hypoxemia. You could relate this question to the compliance curve graph, and that would make it easier for you to relay, but I don't think it's a must in this question to draw that graph. The next SAQ is an examiner's favorite, and it was asked back in 2016, and it was, describe the respiratory effects of adding PEEP to IPPV. This question was really poorly answered back in 2016, so much so that they asked it again in the next sitting in the same year where the pass rate was 57%. As per the examiner report, the key thing that you wanted to understand with adding PEEP to IPPV was that it was a way to kind of offset the reduction of FRC that happens with induction of anesthesia. Understanding that PEEP when applied would help to improve compliance, decrease airway resistance, improve VQ matching by helping to recruit dependent airways and hence improve oxygenation seemed to be the key theme in the examiner reports. What was also key from the examiner report was making sure you didn't forget to mention the negative side effects of over PEEP, and these would be that you would shift the compliance curve too far to the right, causing a decrease in compliance with over PEEP, you could cause barotrauma and volume trauma with PEEP, as well as causing shear stress and inflammatory response. So I think the way I would structure this question to make sure I don't miss out on the negative effects of PEEP, because that's a significant part of your mark and understanding, is have a quick definition of what PEEP is and its significance, and then break down that PEEP can be divided into low, moderate, and high categories. And roughly I would say low is 5 centimeters of water, moderate is 10, and high is anything above 15. I would then have a generic statement and say that the effects of PEEP can be beneficial and can be harmful depending on where it sits for a patient to be the most optimal. This would lead on to say that the purpose of PEEP is to help mitigate the decrease in FRC that occurs with anesthesia, and these benefits are to then improve oxygenation, improve compliance, decrease our airway resistance by improving airway radius, decrease the PVR by bringing the lung volume closer back to FRC, prevent damage of the lungs by helping to prevent alveolar collapse, and then all the harmful side effects, so that over PEEP can cause barotrauma, volume trauma, and lead to a pneumothorax. It can lead to breath stacking and decreased expiration rate. It can lead to impeding our cardiac output by decreasing our venous return. And it can lead to poor compliance of the lung by shifting too far right on our compliance curve. You could then finish the question off by some clinical examples and say that PEEP is commonly used to offset FRC. It's commonly used as a treatment for APO, and it's commonly used in patients that have respiratory failure. The other way you could think about this question is back in that systems approach, where we thought about the effects on mechanics of breathing, so the effects on airway resistance and compliance, the effects on gas exchange being the effects on VQ matching and closing capacity, and then the effects on control of ventilation in helping to maintain O2 and CO2, and then finally the effects on pulmonary blood flow. But I think as long as you classify PEEP and put it into categories at the start, you won't forget the harmful effects. The other thing I want to mention with questions about PEEP is that you need to read them very carefully. In KICM, there's been 2 questions about PEEP that if you didn't read carefully, you would go down the respiratory part and not think about the cardiovascular part. In 2009, in the KICM exam, they were asked to describe the physiological consequences of PEEP. So here you would need to cover both respiratory, cardiovascular, and then additionally the effects on renal system, the liver, and on cerebral blood flow. The other time in the KICM exam, they pretty much blatantly asked to describe the effects on the respiratory and the cardiovascular system of applying 10 centimeters of PEEP to a healthy mechanically ventilated adult. So just be careful with PEEP and make sure you read the question very carefully. The next SAQ that was asked was from 2020 in the ANSCI exam, which was discuss the effects of aging on the respiratory system. This only had a pass rate of 49%, and again, it's not a scary question as long as you have a structure to it. Essentially, the examiner report said that the major domains that were assessed in this question was the mechanics of ventilation, so in particular changes seen with aging on the thoracic cage, lung parenchyma, and the respiratory muscle function. The next domain was ventilation and perfusion, in particular the effects on volumes, capacities, and VQ matching. And then finally, the last domain was control of ventilation. This examiner report is actually where I got my structure from for these questions for respiratory physiology, and I'll just break it down exactly how they say in this answer. So we talk about mechanics of breathing, we talk about gas exchange, we talk about control of ventilation, and then I just add in the upper airway reflexes so I don't forget it, and the clinical implications. To answer this question, you can have a brief fluffy statement about what aging is, and you can say it's a time-dependent process where there's a decrease in physiological reserve. There are multiple changes that occur within the respiratory system that have significant implications leading to a decreased ability to compensate in respiratory distress. Then go into your systems. So you talk about mechanics of breathing and say that the airway resistance is increased due to a loss of radial traction. You say that the compliance is increased in terms of lung compliance because of the loss of the elastin, allowing lung compliance to improve. However, chest wall compliance is decreased due to the ossified ribs and the hyperkyphosis that occurs with aging. And overall, this leads to a decreased respiratory compliance. Together with decreased compliance and increased airway resistance, we have an overall increased work of breathing. And then additionally, with aging, we have a loss of our type 1 muscles. There is not as many fatigue-resistant muscles available, and therefore we have a decreased tendency to be able to exercise for longer. In terms of gas exchange, we know that the closing capacity goes above FRC when we're 65 years old and erect, and this leads to increase in our small airway closures. This creates areas where we can have gas trapping and atelectasis, and so it increases our VQ mismatch. We have changes in our lung volumes overall, so we have an overall decrease in our total lung capacity, an increase in our FRC, but a decrease in our vital capacity. Our overall control of ventilation is poorer and slower, and we're more susceptible to the effects of drugs. And our upper airway reflexes as we age become also dulled and suppressed, and we have an increased propensity to develop OSA or airway obstruction. The real tough question with regards to aging that hasn't been asked in a while was asked back in 2008, where it was described the changes that occur with aging that can affect oxygen delivery to the tissues during moderate exercise. The reason why this question was harder is because of the sheer volume you need to put in this answer. We're not going to talk about this answer in details, but essentially it needed you to be able to quickly and succinctly describe the physiological changes that occur on the respiratory system with aging and the physiological changes that occur on the cardiovascular system with aging, and then marry them together and link them all back up to your oxygen delivery equation, which is your cardiac output times the amount of oxygen that's in your blood. I wouldn't put it past Ansgar to ask this question again, because it did have a poor pass rate of 14%. And the reason I bring this up is because you need quick systems to be able to put in all the relevant and important information quickly with any of these aging or obesity questions. The other question that they've asked previously has been along the same lines, which was describe the effects of morbid obesity on the respiratory system. This was asked in 2017, and again, it's just the carbon copy of the aging question. You just need those headings and then the clinical implication. The unique thing about obesity is that there's a decrease in FRC already due to the cephalad displacement of the diaphragm, and there's an increased oxygen consumption due to the higher metabolic demand. Then we move on to SAQs about hypoxemia, and in 2012, we were asked in the Ansgar exam, discuss the physiological causes of early post-op hypoxemia. This again has a 28% pass rate and is highly likely to come up. The examiner report here said that you would start off by defining hypoxemia. So you would say it's a low tension of oxygen in the arterial blood. You could describe the factors by going through the oxygen cascade, or you could describe the factors looking at the causes of hypoxemia. So remember, these causes are hypoventilation, diffusion impairment, VQ mismatching, and shunt. I personally think that the second way is easier to think about it, and so I would start off answering this question by a quick definition of hypoxemia. The general accepted number is less than 60 millimeters of mercury of partial pressure of oxygen in the arterial blood. You could also state that the importance of this number is that it's on the steep part of our ODC, so anything below this point there'll be a rapid drop in our oxygen saturations. You could then have a statement and say that the most likely cause of early post-op hypoxemia is typically iatrogenic hyperventilation or atelectasis caused by shunt. Then you would go on and talk about your 4 causes of hypoxemia. So you could say hyperventilation can occur due to a multitude of reasons, patient having drugs on board, residual neuromuscular blockade, and relate this back to the alveolar gas equation and show that how an increase in partial pressure of CO2 leads to an hypoxemia developing. You then talk about diffusion impairment and said this is an unlikely cause, but can occur by giving the patient too much volume, leading to an APO. Other rare things could be negative pressure pulmonary edema. Then you would talk about VQ mismatching. This occurs because of our normal VQ scatter due to gravity, and post an anesthetic you might have an ablation of your normal hypoxic pulmonary vasoconstriction, so your normal ability to compensate and match your VQ is altered. There might also be disease states that the patient had that's been exacerbated, like asthma or COPD, or other more sinister causes like hypotension or pneumothorax causing VQ mismatching. Then you could talk about shunt and say that the shunt would occur due to atelectasis. but it could also occur due to an aspiration pneumonitis. It can be increased risk of occurring when patients are obese or have had a pneumoperitoneum. And then the last factor that isn't part of the 4 causes of hypoxemia, but you don't want to forget, is a low FiO2. This can be due to a couple of specific reasons post-op, and that's why it's important to note, such as when you get diffusion hypoxemia occurring because of nitrous oxide being used at the end of the case and then diluting the oxygen that comes back into your lungs. The other rare cause of a low FiO2 will be doing anesthesia at a high altitude environment. Talking about altitude, our next SAQ was from 2009, which was outline the effects of acute exposure to air at an altitude where barometric pressure is 347 millimeters of mercury. What compensatory mechanisms occur with gradual exposure to increasing altitude? The examiner report here wants you to first calculate the partial pressure of arterial O2, then outline the cardiovascular and respiratory responses, and then tie this into the physiological basis of these responses. Additionally, the examiner report also wanted some information about temperature, humidity, light, and radiation, but I don't think that's as important in this question, and it's kind of easy to get information overloaded in this answer. So you can start this answer by first calculating what your partial pressure of alveolar O2 can be by plugging it into your alveolar gas equation. What you'll find out when you do that is that your partial pressure of alveolar O2 is 13, and here you want to clearly state that this low amount of hypoxia is incompatible with life, and you would need immediate compensatory mechanisms in place to survive this. This could lead on to a structure that was a sensor, detector, response, or if you just knew what the responses were, you could just go straight into it. So you would say that initially, the hypoxemia would be recognized by peripheral chemoreceptors. The respiratory effect would be to increase minute ventilation, which would have a compensatory effect of decreasing partial pressure of CO2. At altitude, there's the 3 phases that occur, where there's the initial increase in minute ventilation, then minute ventilation slows down as the CO2 decreases, then finally as your central chemoreceptors equilibrate to the new pH due to the low CO2, we get the restart of your minute ventilation occurring via your hypoxic drive. The effect on your cardiovascular system is to increase your sympathetic output in an attempt to increase heart rate, increase contractility, and increase cardiac output so that oxygen delivery to tissues is increased. And then you have all the other additional responses. So this includes your hypoxic pulmonary vasoconstriction to help improve VQ matching, your shifting of your oxygen dissociation curve, which is complex. Remember, it goes to the right because of your 2,3-DGP increasing, but the main shift is to the left because your alkalemic and your CO2 decreases. You have an increase in your EPO, which helps to increase your red blood cell amount to improve your oxygen carrying capacity. You have an increase in the tissue O2 extraction, and your tissues over time will adapt by putting extra capillaries, and this is done by the induction of your hypoxic inducible factors. And this will also help to increase your mitochondria amount so you can increase your capacity to do aerobic metabolism. So there's a lot already to pack into that answer without having to then talk about the effects of temperature, humidity, and UV radiation. This brings us to our last SAQ for today, and it's one of those SAQs that's actually quite unique to the primary exam. The reason I say this is because it reads more like a Part 2 question. It was asked in 2014 in the ANSCII exam, and the question was, what lower limit of SpO2 would you accept in an ASA 1 young male adult under a GA? Explain the reason for choosing this value. As per the examiner report, they wanted you to explain the values and the relationships between SpO2, SaO2, PaO2, and O2 content and delivery. They wanted you to define hypoxemia and the normal compensatory mechanisms, and then understand that the duration of hypoxemia should also be considered when considering a lower limit for this question. Unfortunately, I don't think I have a really good answer to this question, but the way I structured it is by having my answer at the start and saying that I would have the lower limit between 92 to 94%, and I would accept the lower limit of 92% for a short case and above 94% for a long case. I then went on to explain what saturations are. So saturations are the oxygen amount that's bound to hemoglobin, and then relate this back to my ODC and explain that below 90% we reach this steep part of our ODC curve where we get a precipitous drop in our oxygen saturations. Then the next part of my answer was the rationale. So why would I choose this number? In a normal awake person, the response to hypoxemia is to increase sympathetic nervous system output, increase minute ventilation, and increase hypoxic pulmonary vasoconstriction. I then had a statement that said that all of these normal responses are attenuated in a patient having a GA. Then I went on to describe what the goal of delivering oxygen was, and that was to maintain aerobic metabolism and prevent anaerobic metabolism. The next part in this answer was the rationale for choosing this number, and the rationale was that keeping it above 90% allows a buffer if any change occurs. What I meant by that was, if you keep the lower limit as 90 and say something catastrophic happens, you don't have much time to catch up because you're in the steep part of the ODC. If you keep it just above 90, you at least have a little bit of time to troubleshoot if there is any unexpected issues that arise. For example, the patient might develop a pneumothorax, there might be a catastrophic bleed, or simply there might just be a disconnection of your anaesthetic circuit. Additionally, because normal mechanisms to counteract have been ablated, you want to make sure that you are promptly treating any causes of further decrease in oxygen. So this question had a 30% pass rate, and I would highly recommend making sure you have your own answer to this question. If you find a better way to answer it, please let me know. But this brings us to the end of a very long podcast covering applied respiratory physiology. We have one more respiratory topic to go, and that is measurement. But the next episode I release will be my tips and tricks for the SAQ exam. I hope you guys have enjoyed listening so far, and I'll catch you next time. Until then, good luck with your studying, and make sure you're giving yourself regular breaks leading up to the written.